Hey guys, this is Dr. Hub. In case you haven't subscribed, please do subscribe for updates. Epidural anesthesia, and we are focusing on some very important points regarding this. So first is the epidural space. So what is the epidural space? So let's analyze this. So the epidural space, if you see, it is the space between the dura and the ligamentum flava. So it lies between the dura. So it is a space between the dura and the ligamentum flavum. Next is the dura is not penetrated. So the dura, it is not penetrated. Then the site of action of the epidural anesthesia is nerve roots. So the site of the action of the epidural anesthesia, so we are writing it as EA, is the nerve roots. Next is the method to identify the epidural space. So what is the method to identify the epidural space? So we have the epidural space. So the method to find out will be, first is to the loss of the resistance technique. First will be the loss of the resistance technique. So the loss of the resistance tech, and the second will be the hanging drop technique. So there's something known as the hanging drop technique. So there is a loss of resistance technique as well as hanging drop technique. So this hanging drop technique is known as the Gutierrez sign. So Gutierrez sign is a sudden sucking of a drop in epidural space. So it is a sudden sucking. So it is nothing but a sudden sucking of a drop in epidural space, of drop in the epidural space, The sudden sucking of a drop in epidural space. Next is, what are the methods to confirm the epidural anesthesia? So how do you confirm? So the confirm is by you do a test dose. So there is a test dose. So this we already covered it, we'll just recap. So we have a test dose and there is a 3 cc. So there will be a 3 cc of the lidocaine. So 3 cc of lidocaine, and you combine it with the 15 mcg. So you have a 3 cc of lidocaine and then you combine it with a 15 mcg of the adrenaline. So 15 mcg of the adrenaline. So this will be about 1:200,000. So this will be up to 1:200,000. So this will be intrathecal injection, will produce a spinal anesthesia. So the intrathecal injection. So we call it the intrathecal injection. So intrathecal injection will produce a spinal anesthesia. So this will produce a spinal anesthesia. And that is the lidocaine. And that should be rapidly apparent. So this should be rapidly apparent. Next is the intravascular injection will produce a significant tachycardia. So the IV will produce a significant tachycardia. So it will produce a significant tachycardia, and this will be 25% or 20% above the baseline. So 20% above the baseline. That is the adrenaline. Next is the Durant sign. So what is the Durant sign? So Durant sign is a rapid injection of the drug in the epidural space. So it is the rapid injection of the drug. So you have a rapid injection. So this drug, there is a rapid injection of the drug in the epidural space. So you inject it in the epidural space. And it causes an increase in the rate and depth of respiration. So there is increase in the rate as well as increase in the depth of the respiration. So increase in the rate and depth of respiration is seen in the Durant sign. Next is the Westphal sign. So what is the Westphal sign? So Westphal sign is the absence of the knee jerk after the epidural anesthesia. So Westphal means there's absence of, so there's negative knee jerk. So there's negative knee jerk after the epidural anesthesia. We are writing it as EA, epidural anesthesia. Now, what is the anesthetic of choice in epidural anesthesia during labor? So the DOC during labor. So during labor, we administer the bupivacaine. So we administer something known as the bupivacaine. Next is the epidural narcotic preferred over the epidural local anesthetic. So the epidural narcotic. So epidural narcotic which is preferred over the epidural local anesthesia. So epidural LA, that is a local anesthesia. So this is because of the absence of the motor paralysis. So the reason behind this is the absence. So there's absence of the motor paralysis. Motor paralysis. Next is, what are the drugs used in epidural anesthesia? Epidural analgesia. So in terms of epidural analgesia, the drug which is used is morphine and fentanyl. So you administer morphine as well as you administer the fentanyl. Next is the epidural opioids. So the epidural opioids act on the dorsal horn. So if you look at the epidural opioids, so you have the epidural opioids. So these epidural opioids, it acts on the dorsal horn. So there is a dorsal horn. So dorsal horn of the substantia gelatinosa. So it acts on the dorsal horn of the substantia gelatinosa. And it may cause the pruritus as well as the respiratory depression. So this is about the epidural opioids. So it leads to the pruritus. So there is pruritus as well as the respiratory depression. So pruritus and the respiratory depression is seen. Next is, the drug is not given in the central neuraxial block. So the drug is not given in terms of the central neuraxial block. So in terms of the central neuraxial block, it is not given in the central neuraxial block or the caudal block. So what is this drug? So this drug is nothing but the remifentanil. So it is a remifentanil. Now let's look at what is the walking epidural. So here, what is the walking epidural? So walking epidural is the ultra low dose epidural. So walking epidural means the ultra. It is the ultra low dose. So it is nothing but the ultra low dose epidural. So it is the ultra low dose epidural, and it is used especially for the labor. It is used specifically for the labor, and it is only the sensory blockade. It is only the sensory blockade. Next is the complication of the epidural anesthesia. So what are the complications of the EA, that is the epidural anesthesia? So this includes a total spinal anesthesia. So it is a total spinal anesthesia. Now, which is not a complication of the epidural anesthesia? So which is not a complication of the epidural anesthesia? So this includes the DIC, disseminated intravitreal coagulation, as well as the headache. Then comes during the epidural anesthesia. So during the epidural anesthesia. The sudden hypotension is due to the drug entering the subarachnoid space. So in terms of epidural anesthesia, the sudden hypotension. So what you get? You get a sudden hypotension. So sudden hypotension is due to the drug entering the subarachnoid space. So this will be due to the drug which enters the subarachnoid space. So we call it the SAS. So it's a drug which enters the subarachnoid space. So this leads to the sudden hypotension. Now let's look at the most commonly used needle. So what is the most commonly used needle in terms of epidural anesthesia? So the most common used needle in epidural anesthesia is going to be the Tauhy needle. Tauhy needle is nothing but TOUHY. So Tauhy needle. So this Tauhy needle is nothing but 16 to 18 gauge, and it has a blunt bevel with a curve at the tip. So it has a blunt bevel. So what is the characteristic? It has a blunt bevel. So there is a blunt bevel, and this is with a curve at the tip. So it has a presence of a curve. The curve is present at the tip. Now this blunt bevel, it helps to push away the dura. So there is a blunt bevel, So what is the use of this blunt bevel? So this blunt bevel, it helps in pushing away the dura. So it push away the dura. So it push away the dura. So it will push away the dura and after passing through the ligamentum flavum. So it will push away the dura after it passes through the ligamentum flavum. So after it passes through the ligamentum flavum. And instead of penetrating it. Next is the curved tip, it decreases the incidence of the dural puncture. So this will be an important point. So the curved tip, so there is a curved tip, it decreases the incidence. So it decreases the incidence of the dural puncture. To learn and grow daily like this, please do subscribe.